three pneumonia, less than 3 pneumonia deaths per 1,000 births. And then we're projecting that out. That was 2025 when the report was published. We project that out to 2030 and bring it down to 2. So now you can see just how many pneumonia deaths the world can tolerate, if you like, child pneumonia deaths, to achieve that target. The orange line is the official UN child mortality estimates. Everyone knows we have two sort of estimates here that we work with, and the blue one is the global burden of disease. We like to keep our eye at every breath counts on both of them. It's very important that we don't just have a monopoly on these estimates because they're extremely, they're very fragile. So we follow both, but we're very much focused on the GBD 2021. It's the blue line. If you look at what happened during COVID, childhood pneumonia deaths came down to about 502,000 due to COVID, according to GBD, because of the infection control efforts around COVID. They reduced the transmission of pneumonia infections amongst children. So if we project out, if we can hold that down and project out, by 2025, which is next year, pneumonia deaths need to be 397,000. And then take that through to 2030, 266,000. So we have to have a system that can reduce our current mortality around 500,000 down to around 400,000 and then on down to 266. These are not huge reductions in childhood pneumonia deaths globally to achieve these goals. We are much closer than we think. So just to remind you, this is a very happy slide of all the tools now in our kit to prevent, diagnose, and treat childhood pneumonia deaths. On the left-hand side, the green, it's where we all love to be. It's better to prevent than have to treat a sick child. Look at the vaccines. We've already got PCV, Hib vaccines. Of course, they're not the coverage they need to be. We need to lift the coverage. But look at the pipeline. RSV, maternal vaccine, and monoclonal antibodies for the infants. Klebsiella pneumoniae, maternal vaccine in the pipeline. GBS, group B strep, maternal vaccine in the pipeline. So look at how strong our vaccine portfolio is going to get. Then you've got all the other prevention strategies at the bottom. They're at reasonable coverage, not great. Then if you have a sick child, let's move to the right-hand side of the white line. There's all the bacterias and viruses that are driving childhood pneumonia deaths. It's really important that we get that granular. We have to be talking about pathogens now. In a much more detailed way, and the diagnostic tools and treatments. Now, while it's true that the children in low resource settings that are dying do not get all of these tools, we need to remind ourselves we have them, and the challenge is to get them out. So the other piece of news that I think is really important is we don't have to be working everywhere to have this impact. Child pneumonia deaths are becoming extremely concentrated as countries, move forward with their health systems and their growth, and they take care of this problem. But in these 20 countries, we have 80% of childhood pneumonia deaths. The red ones are where the largest numbers are located. The orange ones are lower numbers, but still very significant, and then we get into the yellows. So 80% in these 20 countries. This is where we need to be focused. There's still a lot of activity in global health that is in countries that, frankly, do not need the support. So we need to come together on a list of priority countries. So last slide, what should the 5 priorities be given these? I've just given you a taste of this slide deck. We can give you more later. What should the 5 priorities be? Every Breath Counts argues in the countdown to 2030. Number 1, 90% plus coverage of all those existing pneumonia vaccines, but also the pipeline, the RSV vaccines and monoclonal antibodies. We have to get serious about coverage of those. Number 2, accelerated development of the pipeline pneumonia vaccines, Klebsiella pneumoniae and GBS. They're maternal vaccines. So we have to get very, very much into the space of maternal vaccination, those of us who are fighting childhood pneumonia. Number 3, integrating malnutrition prevention, diagnosis, and treatment. All these amazing new nutrition tools we have, the SQLNS, the newborn probiotics that Gates Foundation is really investing in, the therapeutic foods and the maternal micronutrient supplements. They will not get to children, or women for that matter, without an integration with a platform that's already reaching those populations, and that's vaccination. For too long, the nutrition community has tried to set up separate distribution networks. Forget about it. Our best chance at getting these malnutrition protections out is through the vaccine system. Let's not forget that malnutrition drives more than 50% of childhood pneumonia deaths. Number 4, the area where I think is our weakest link in the chain, diagnosis and treatment. We have to have pulse oximetry oxygen at high coverage, effective antibiotics for sure, but the pneumonia diagnostic space is still frankly lousy. We need a rapid diagnostic test. We need to differentiate bacterial from viral. There's a lot of innovation. I see some people in the room here working on it. Cough sounds, lung ultrasound, all AI enabled. This should be a massive growth area in pneumonia diagnostics. We need to invest more in it. And then number 5, we just need to have our eyes on mitigating these risks of respiratory and AMR. COVID did not disproportionately impact children. It was adults who were hit. It may not be that way the next time. Can you imagine a world where there's a pandemic of respiratory infection targeting little children? We have to prevent that from ever happening. And AMR, there's a huge agenda now to mitigate AMR, and we need to get on board with that. So that's what we think are our top 5 priorities in a lightning round. We think the union is an absolutely critical addition to our tools as a pneumonia community to get at these priorities. So we're super excited about this group, and we're going to put a lot of time and effort into making it successful. Thanks so much.
Thanks so much, Liv. Yasir, you're next.
Hi, everyone. Very nice to see you all. And thank you very much for giving me this opportunity to present some of the work which WHO has taken place for the last few years. I will also start with GAP-D. Thank you, Lee, for highlighting GAP-D, because GAP-D is a global action plan for prevention of pneumonia and diarrhea mortality. And we actually put these interventions into 3 areas: protect, prevent, and treat. And WHO is working in all these 3 areas with different research, development, implementation, and policy change. I will talk more about treatment because that is what my department and myself is working more, but other departments are working in the nutrition and as well as in the immunization. Under treatment, we have broadly these 4 or 5 major interventions, such as improved care seeking and referral system, then case management at a lower level, community level, and the primary level facilities, and obviously supplies, but at the hospital level or at the higher facility level, availability of pulse oximeter and oxygen, and then continuous breastfeeding as a preventive measure. So broadly speaking, I categorize WHO work into 3 major areas. So first major area is evidence synthesis and evidence generation. This is one of the core responsibility of WHO, and for the childhood pneumonia, we broadly divided into 4 major categories. The first is evidence synthesis. So WHO actually commissioned some of the academic institute like Melbourne University a couple of years ago to do a comprehensive reviews on not only on the management side, but also on the preventive side of intervention, where we are and what are the scope over there. Based on these scoping reviews, we conducted a consultative meeting, and then we convert into a guideline process, which I will discuss tomorrow more in detail. At the same time, now currently we are doing some more evidence synthesis around use of pulse oximeter, especially at the primary level health facilities, because after COVID, we have noticed that many facilities now have the availability of pulse oximeters. But at the same time, we have noticed that these are mainly for the adult population. And we all know that for the pediatric population, they need a different probe. If they are using the adult probe, there is a chance of miscalculation of the SpO2. And the third major activity under evidence synthesis, we have pooled data from about 46 different studies. And few of them are sitting here, which contribute their data sets. And we actually did our patient level, our individual level pooled analysis to see some of the intervention and the new area in terms of research. It's a big data set, more than 300,000 cases of pneumonia, both at the hospital level, at the community level. And if anybody would like to do analysis, we have published 5, 6, 7 papers, and we use this data also to update the guidelines. So I welcome all of you if you want any of these. I will share those papers with you if you want more analysis in other aspect of this data set, because this is very unique data set. Then in terms of research ideas, we did some exercise during the development of the guidelines or updating of the guidelines last December. I will talk more tomorrow about that. But at the same time, WHO is also generating evidence on different aspects of management of pneumonia. Especially, we are conducting implementation research, how to improve the pneumonia treatment coverage. And this is a multi-country project where we are actually testing a district level implementation or delivery model and see how we can scale up pneumonia treatment coverage in low and middle income countries. 4 countries are 2 in Africa and 2 in Asia. And this, we are also doing some observational studies to see what is happening at the primary level facility, because in many of the countries, the training is there, but actually what is happened in the field, there is a lack of data. So we are collecting this in 7, 8 different countries in both in Africa and Asia, and going to publish it in a journal supplement, all this evidence, which will help many other countries to strengthen their primary level facilities. And lastly, we are also providing technical support wherever it is possible for studies such as UNITAD did major studies around pulse oximetry for the last 3-4 years. It seemed like on ultrasound, some of the groups are doing their studies, so we are providing them technical support. In terms of monitoring and evaluation, sorry, I think there is a one missing. Yeah, policy. First is the policy and program implementation. So in terms of policy and program implementation, we are supporting different countries, all in low and middle income countries, to have updated pneumonia guidelines, which is being implemented not only at the district hospital level, but at the lower facilities, even in the community level, because we all know that the burden of disease is not in the hospital, it's more in the community level. And it's very important and necessary to identify these children with pneumonia at the lower facilities and in the community. At the same time, we are actually updating pneumonia guidelines, and subsequently we will update the pocketbook, which is used to be for our district hospital. IMCI, you all know about IMCI, it's the Integrated Management of Childhood Illness, and being implemented at the primary level care facilities, and then ICCM, which is Integrated Community Case Management, which is for community health workers to identify and manage some of the cases of pneumonia. We are also providing technical support to the member states to adapt these guidelines and change in the policy as well as in strategy whenever it is possible. And lastly, I mentioned about the implementation research, because many of the countries actually they change their policy and strategy, but once they would like to implement, then they are having difficulties, because it's some activities are context specific. We have seen that there is a lot of variation even in the community health workers level of training and education. So it's not like one community health worker which can work in one country, it's the same community health worker in another country. There is a lot of variation in their training as well as education. So lastly, about monitoring and evaluation, we are continuously developing new indicators, how to monitor at the programmatic level to see the success on whenever there is a challenge, how to overcome those challenges. We usually do a policy surveys every 5 years. Last time we did it in 2018, and now recently we have completed in 23, 24. And pneumonia is part of that policy survey to see that where are the countries with policies, have they adapted the latest policy, which is being implemented through WHO and UNICEF, of course. And lastly, this activity monitoring and evaluation also highlighted research ideas, when to do, where to do, and how to do research in the new areas, such as newer diagnostic tools, improve coverage of the treatment, and referral pathway. So some of them I will talk about tomorrow in the plenary session, but I think in brief, this is my last slide. Yep. Thank you very much. If you have any question, I'm here. We can discuss later on. Thank you.
Thank you, Yasir. Joanne, do you want to come up?
Hello, how are you doing? It is not intimidating at all to be up here. That's what I'm telling myself. But like I mentioned, my name is Joanne Charlo, and my background is in medicine, so I am a doctor. And then one of the questions I get a lot, like, how do you go from clinical practice to working with a medical manufacturer? And maybe a little bit about my background, why that actually happened. So I'm from Uganda, and currently I'm based in Nairobi. And during my medical training, I got a chance to train in a few different parts of the world. So I did some rotations within Abu Dhabi in the UAE. I did a few in Chicago, and I did whole of my last year in Mexico, which really gave me a wide experience of medical practice and what different healthcares, look like, and what patient care looks like. And coming back to work within East Africa, I've worked in Rwanda from district hospital to referral hospital. I realized that a lot of our mortalities are really preventable. We lose very young patients. And I remember seeing, the mortalities I would see in some of these other countries where you lose an 80-year-old who's been on dialysis for 30 years. And they've really lived their lives, and coming back to moving, a 17-year-old or younger children. And sometimes the access is, the issue is like, I could only give them 15 liters of oxygen. And the next step up is ventilation, where sometimes you don't have ventilators, you don't have access to ICU beds. So why am I really passionate about this? So, looking at what are some of the things limiting factors to us treating patients really well in LMICs is access. You don't have what you don't have, and you don't know what you don't know. And so I want to focus on nasal high flow. So when I came across Fish and Paykel and what they're trying to do in this space. So a little bit about Fish and Paykel, and we have some Kiwis in the room. They're very familiar with Fish and Paykel. Fish and Paykel has been around for over 50 years and is we specialize in respiratory therapies, from high flow bubble CPAP, and also dehumidification systems for ventilators. So this is very much our expertise. And when I came across what Fish and Paykel is doing, especially with high flow, is you're able to really give good respiratory support using very easy technology. And given that the focus is on pneumonia and what you're able to do, we have made some strides. I feel like in this space we've made, ever since COVID, there has been a lot of work done by organizations like, Every Breath Counts, WHO, different partners, to really shine a light on oxygen therapy within the hospital setting, which is, as clinicians working in LMICs, we've already known the problems, but it was kind of difficult to have conversations with people to even be like, hey, we need an oxygen plant in our hospital. That was not a thing. That wasn't a thing. But now this is work that's been done because of, a lot of it is because of COVID, but we're here, we are focusing on pneumonia and how do we, improve outcomes in those pediatric patients. So I want to kind of like moving into high flow. What happens when conventional oxygen is not enough? Yes, we're putting plants, we are making oxygen accessible, but how are we delivering it to the patient, right? Normally you'd escalate to CPAP or vent, but knowing the issues we have, sometimes that's not accessible to you. Sometimes maybe you have a vent, but you don't have the expertise, or you have really great bubble CPAP or really great therapies, but your patient to nursing ratio is kind of out of work. So you have, 1 nurse to 30 babies. It is impossible to sometimes deliver really good therapy if you do not have the patient, the human resource to deliver it well. And then again, you need the critical care experience sometimes, or you need to really do great training. And if you've trained anybody in some of these therapies, it can be challenging. You need to go back and you go back. And sometimes that, again, given our settings that, majority of our care is given by students or moving staff, that might not be possible, right? And then sometimes you have to transfer your patient to a different place, to a different hospital, as a referral hospital, the distance. So basically, these are all problems we all know, right? So what are some of the solutions? And the reason why I wanted to focus on nasal high flow therapy is because it's such an easy therapy to deliver, but also not maybe a little bit about what it actually is, because we hear a lot of different things. It's basically being able to deliver high flows of warm, humidified air. A lot of times when we say high flow, people imagine it's immediately high flow oxygen. When you think about the fact that there is not a lot of air in a lot of our hospitals, and given the pediatric population and how important it is to be able to give blended air, using a device that's using room air, and you're able to blend without getting an air source, that's already solving an issue, a challenge that we have. You're able to meet or exceed the inspiratory demand, which is one of the ways you say, to help with the work of breathing, and you'll see decrease in respiratory rate. It is you are warming and humidifying the air, which also means you're delivering it at the core body temperature, or at a temperature that would normally physiologically your body will do, you will have to do. And when you think about a child who is working really hard to do all that work, they're losing weight, their work of breathing, they're getting tired. Having a device of therapy that's able to do that, and also with washout, CO2 washout, you wash out the dead space, improves improves ventilation. With a little bit of PEEP, you're able to extend the alveoli to kind of help that baby, breathe. And you see that, the effects of, or the response to the therapy quite quickly. And it's a very practical, an easy device right now. What we are doing, and maybe to share a little bit of experience that we're seeing, because a lot of questions we ask, this is not a therapy that can work in LMIC. This is not a therapy we can see. This is not a therapy that is able to do training and all that. Currently, MSF is using it, and they're seeing a lot of great responses, right, in treating very small babies, from neonates to pediatric patients. In Kenya, we know that in Mbagathi and a few other places, clinicians are using it, and some of the stuff clinicians have told me, pediatricians, like, hey, it's actually easy for my nurses to use this therapy, and that means for those who really need the pressure therapy, which is high flow, we are able to give it. They're able to actually deliver it well, because now you're helping to kind of with the issue of human resource, right? You're having some children use high flow, getting great responses because you're just putting a cannula. You don't need a lot of monitoring. And those babies, especially the preemies who really need the pressure, are able to get really good CPAP. And another, example is Zambia, where PATH, installed some of those devices in UTH. And some of the feedback we have got, this is a public hospital, teaching hospital, human resources moving, you have nurses and students, but the fact that even education using the app, we have an app that we use to train, they have been able to pass on that knowledge. So meaning this is something that we already see is working and is feasible within this context. But we also know LMICs normally will only be able to use or implement therapies if there's guidelines from WHO. This is why it's great to have WHO in the room. And it is so important to have the right data. And we know a lot of these guidelines are, driven by data. And currently, there's not a lot of data. We are very aware of that for LMICs. There is a lot of data. There is data already in high income countries where we shows outcomes, implementation that is being done. But we also know the limitations of importing that to these settings, which has unique hindrances. So I've quoted some of it. And I know I'm running out of time. I won't go through each one of them. But I think part of it is that we have seen indications of how this therapy can have actually really great outcomes. But there is also a need for more research around it. This is why I'm really excited to hear that part of, this group's work is like, hey, how do we develop more evidence? How do we generate more evidence to inform the work that we're doing, to inform, so our question really as industry and as, a company that has a lot of experience in this area, this is our expertise, and we want to be like, hey, how do we collaborate? How do we create some solutions that are fit and specific to this region of the world? And a lot of LMICs around the world, not just in Indonesia, but around the world. And really our interest is collaboration, and we are happy to have conversations around how do we contribute to that, what questions you want to answer, because we know that even with the current guidelines, they pose a lot of questions that are yet not answered in LMICs. Thank you so much for your time.
Great. Thank you. Anybody from Chai want to comment? I don't know if
Hey, Eric.
Oh, you're there. Okay, great, Zachary. Let me
Yeah. Hi.
You want to share anything?
I do. Can I put something on the screen? I can figure it out.
Perfect.
While I find it, so my name is Zachary Katz. I'm the Vice President of Child Health at Chai. So that is covering pneumonia, diarrhea, vaccines, and nutrition, as well as quite a lot of work on oxygen over the last couple of years. Let me see. I'm having a little trouble finding this. Well, anyway, I'll start to talk through it, and then hopefully I can find it as we go. So CHAI is the Clinton Health Access Initiative. I believe some of my colleagues are there with you in person. Some others are here on the phone along with me. We are an NGO based on, here we go. We are an NGO based in roughly 35, 40 countries and have a number of global teams as well focused on various issues. Can you see my screen?
Yeah, yes.
Okay, great. So it's a little bit of a mishmash of slides, but just in terms of what we've done on pneumonia, so we have worked on pneumonia since roughly 2015. We had a focus in 4+1 country as here, but just to say we took a four-pronged approach in our program model in terms of negotiating lower prices for equipment, strengthening policies and guidelines, improving access to oxygen, and then developing monitoring systems to manage and understand performance. And we had some really great results across the countries where we worked. Here on the right side of the screen, you can see some baseline and end line around access to pulse oximetry, access and use of pulse oximetry, as well as access and delivery of pneumonia to children who need it. Sorry, here we go. We also did quite a lot of work in helping support local markets to expand accessibility to amoxicillin dispersible tablets. And you can see we increased the number of locally registered products in many countries and saw some great increases in the availability of amoxicillin in public facilities for childhood pneumonia. That I'll skip this one. I mean, in addition to sort of some of that more national work, we also saw some really great, I'd say more targeted approaches within hospitals that were really about increasing access to pulse oximetry and oxygen use. And this is an example from some work we did in 2 regions in Uganda, where we saw a pretty big reduction in hospital pneumonia mortality rates as a result. And kind of as that work, I would say, tailed, we came to COVID, and as many of the colleagues that have already spoken, including Leith, will know there were really not a lot of organizations globally who had any kind of expertise in oxygen systems. And so we found ourselves over the last, let's say, 5 years, really pulled into oxygen. And, at our peak, we were working on programs in roughly 20, 25, 30 countries, really about access to oxygen, whether that be oxygen systems, bigger systems like PSA or liquid, concentrators, or some of the delivery systems that the previous presenter talked about. It was really a mix, and really about emergency response. And so just a few photos of the things we did here. This one I like to show because it's the Prime Minister of Lesotho launching the two big tanks you see there in the back right, which are regional hubs of liquid oxygen for the southern region of Lesotho. But even down to things like cylinder trolleys and things to just make access to oxygen a little bit easier. We're now post-COVID. We're down a little bit, but I left this up because our work is still very oxygen access related, and we are focused across now roughly 15, 16 countries doing that. To kind of try to summarize where we are in terms of our strategy, we are essentially trying to take the emergency response, the COVID emergency response, and ensure that the infrastructure that was put in place, which is well over $500 million, to make sure all that infrastructure that's in place in the countries where we work can be used in perpetuity through its full lifespan. And so what that means is really shifting from emergency mode and procurement mode into sustainability mode. So, establishing and institutionalizing oxygen task forces and strategies. It's about normalizing oxygen in the inclusion of national budget, but also increasingly oxygen is available or it's allowable in the Global Fund, for example, or in GFF, for example. And so working with countries to ensure that there are budget lines for oxygen going forward, whether those be buying the oxygen itself or the maintenance or the delivery systems, et cetera. We're doing quite a lot of work on market shaping, particularly in the liquid oxygen market shaping space. Liquid oxygen, as many know, maybe many don't know, is a industrial product that's used very, very frequently in medical for in higher income countries like in Switzerland where I'm sitting today, and then of course all the moving from emergency trainings to really expanding trainings nationally into hospitals and settings where people who require oxygen are, particularly children. And ensuring that inpatient wards, inpatient pediatric wards have high coverage, kind of looking forward at the use of all the oxygen equipment that was delivered, data systems as well. But I wanted to get to this last slide because I just added it as we were talking, because I thought Leith's last slide was really important. And this is an old slide that really only focuses on pneumonia treatment, on finding kids and treating them. And so there are a few things missing, but I was really struck by the overlap in between what Leith was saying and what we've thought about as well. And so the two things I would add here before I go through this list are, of course, vaccination and like pushing. There are still places where PCV is quite low. So pushing PCV, pushing HIB, pushing the things that we have already to the limit. But for the many, many children who either fall through the cracks or still suffer from pneumonia, in agreement with Leith, there's a lot of things that I think we can do on the CHAI side. And these are some things we would like to focus on increasingly. So, number one, ensuring that There's community access to the best available diagnostic tools, whether those be pulse oximeters, multimodal devices. Someone mentioned some of the newer technologies, which I'll get to. As a father, my children get sick all the time. Even my own care-seeking behavior for them may not be fast enough. Luckily, I live in a place where that there's catch-up available. But for those identification tools to be available in the communities or closer to the communities, we feel is maybe the absolute paramount. Then, of course, there are a lot of new potential diagnostic tools for improved pneumonia or for improved, screening in of possible pneumonia. And so, having a sandbox or having a place where those can be looked at, understood, possibly tried out if they merit it, is also really important. And CHAI, as a group that works directly with many ministries of health, has worked a lot on new product rollout. We feel like this is a place we might be able to partake. Within these new potential tools, of course, are the ones that were mentioned, maybe all the imaging, sounds, other things that the improvements in technology and AI might be able to help us, again, like screen in or screen out people through ultrasound, lung sound, cough sound, etc. We want to ensure that there's availability of antibiotics. Of course, antivirals are very, very important. I think, if you, and maybe there's a discussion we can have, but, in terms of lower hanging fruit, antibiotics are probably a little bit easier. Amoxicillin DT, as in our experience, scaling that is very, very possible. And we've had some success doing that, and so we feel like that can be replicated in a number of other countries. And then, of course, ensuring access to oxygen increasingly. And whereas pre-COVID that would have been a sentence full stop, just ensuring access to oxygen, I think now there's much more nuance associated with it, and it's really about the slide I showed earlier, where how can we prioritize oxygen availability for these particular patients who are amongst the most vulnerable. How can we ensure that that all of the equipment and expertise that came in during COVID can be, maybe even slightly reoriented towards some of these higher and more vulnerable groups, like kids with pneumonia, in the services where they are seen, whether that be at the primary health level, or as referral moves up into those, inpatient, outpatient, pediatric wards, and so forth. So I'll end there. Thank you.
Thanks so much, Zach. I'm just going to reshare my slides here. Okay. Great. So thank you for those partner updates. And just to kind of state again, having a group with key partners is really, really important. And I just want to publicly thank, Leith from Every Breath Counts for all of her support. Has been instrumental. Yasir from WHO, Joanne and Abby from Fisher and Paykel, and really look forward to further strengthening partnerships and collaborations with Zach and at CHAI and colleagues as well, and as well as other groups, in the room. It's really, really key for the success of this group and moving forward on child pneumonia. So this is what we have here now is kind of an outline, I would say, of the next 2 years. All of it is up for negotiation and discussion. Nothing is set in stone, but it is kind of, as the dust has settled from the last year and a half, in our infancy as a kind of a group. And I do want to just point out, Steve Graham's in the room, and Steve has been an incredible advocate for child pneumonia and has worked within the union for years in this space, and really that this group is a continuation of his earlier work. And it'll be really important to get Steve's inputs and guidance, moving forward on how to best be useful, as we say. We hope we can be more useful, and it's really important for us to be useful from the ground up. And so some of the things that we identified over the past year and a half that we need as a group is a kind of a dedicated coordinator. As much as I wish I could be on email all the time, and I'm sure Rebecca feels the same, and Matt, who I think is online, we recognize that this is a gap, and so I'm happy to share that our Johns Hopkins Respiratory Global Program will be able to support this position over these next 2 years, if not longer, and we'll nest these responsibilities within a coordinator who's based in Baltimore. And so this person doesn't yet exist, but will within the first quarter of 2025. And we really think that'll smooth out a lot of what you'll see kind of below here. So, in general, I think what we want to achieve is something where we're not just a once-off meeting group, where we just meet once a year like this, and it's only those who can make it to places like Indonesia, which is probably far away for a lot of us. We want it to be something where we're touching base, but maybe not overstepping as well, because again, that can be something that we want to do. We want to kind of hit that sweet spot where we are useful. And so that's kind of where we're coming from. So in terms of our engagement with group members, what we are thinking is that we would have kind of 2 strategic planning meetings per year, about an hour long, around March and September of this forthcoming year. And then in the middle of that, we would plan to have our scientific webinar again, which we thought that could be a kind of a successful platform. So in essence, you can envision a scenario that when we hopefully stabilize and streamline our activities, that we're touching base virtually 3 times a year, and then hopefully in person for a lot of us once a year, around every 3 to 4 months. And then kind of in between that, we were contemplating some of the scientific advocacy things here. So I'll get to number 3, which is the scientific advocacy. So maybe I'll just take a step back for a moment as well. And this is even a step back, maybe 2 steps back. It's something that we were talking about earlier. Steve Howie, Rebecca, and Yasir and I we have our plenary session tomorrow. It's a really important opportunity to put forward, child pneumonia to, a group that is largely a TB group. I think, looking around, about 98% of the content is TB. And this is supposed to be a broader lung health meeting. Child pneumonia is very important, leading infectious cause of non-neonatal death globally for kids. And in the context of TB, we were trying to think about how can we best convince folks here that child pneumonia fits within kind of a TB conference, in a TB group. And part of it we'll try to sell tomorrow during the plenary session, but and a lot of, and Steve Graham can speak to this in his published work. A reasonably large proportion of pediatric TB is coming from failed child pneumonia treatment. And so we can kind of think about child pneumonia as really the entry point for a large proportion of pediatric TB. And for those cases of pediatric TB to be successfully treated, we really need a place for child pneumonia to have a home. And, right now, what's, unique to child pneumonia, and this is, there have been a lot of really important efforts. Leith has made a huge amount of efforts in terms of organizing global meetings in Barcelona that have been absolutely fantastic. What we kind of envision here is a place that can be have some function and again be useful within the child pneumonia space in a kind of a more ongoing manner, and that does not yet exist. The other kind of conference group that has started to do some more child pneumonia work, which is fabulous, is the ISPPD meeting. We have not engaged with them yet. I happened to be at that meeting. Yasir was there, and Steve was there as well. And I don't know if Steve, you made it to that meeting. No, you weren't at that meeting, but that meeting had a good amount of child pneumonia content, and they've rebranded one of the P's in ISPPD is for pneumonia. But that conference is more of a once-off, and it's once every 2 years. And so I still think that we think that this can really fit within the union kind of structure. But some of the challenges that Rebecca has alluded to is kind of finding our footing, within kind of a TB group. So with that kind of 2 steps backward, kind of getting back to the slide here, the number 3 here, that's the scientific advocacy part. The plenary, accomplishing the plenary is really a big accomplishment, and we know it'll be really successful tomorrow. Moving forward after the next 2 years, we do need the union to commit to having some intellectual space, some dedicated space for child pneumonia here. There just doesn't seem to be a lot of content at the moment. And for this to be successful, there needs to be a reason for people to come here within the child pneumonia community to participate in the conference. So that is something that we're gonna have a meeting with the union about to kind of to discuss that kind of frankly. And I think in large part we can do a lot of things kind of outside of this specific conference, but this is kind of the anchor of the whole deal. So one thought, and Steve Graham has led this previously, is having a kind of a child pneumonia symposium. I would say at least one, which would be about a 90-minute or 2-hour session during the conference, preferably not the last session of the conference, but earlier in the conference. But having, negotiating one of those each in the next 2 conferences, 25 and 26, would be, I think, a realistic step forward. The mid-year scientific webinar is something that we can commit to, and we would plan for that, in June. And then we would plan again for this hybrid working group meeting. I think the next meeting next year, I actually would have to double check, is going to be in November. It's typically in November, I think. Have they said where it's going to be yet? No, not yet. Okay. And then the other thing here that I wanted to get to, and this is where the coordinator position can help us, is to have a monthly kind of email circular with child pneumonia science, where we can have kind of maybe a quick and dirty literature review that our coordinator can do, and then can send this out to the members as just a touch base that these are some of the new studies that have been published. Helps us kind of keep track of what's moving forward. If there's any programmatic, kind of advances, when the IMCI guidelines, come out, these are the sorts of things that can be communicated through that. And that can be something that can be dedicated to this coordinator position. And so that's at least what we have on paper right now around the scientific advocacy part. And then the fourth one is where more of the funding is needed. And this is around the development of kind of the child pneumonia champion concept. And I didn't harp on this in the slide on the beginning of our meeting today, but this is really where we get into the research capacity building. And I think it's really critical. It's something that we really, really want to do. And so the notion of this is really maybe twofold, potentially. One, idea to make the conference and make the group useful is to have a child pneumonia workshop that's before the conference. So in this case, conference, if I have my days correct, started yesterday. So this would have been something that happened on Monday, where there's some child pneumonia skill building for healthcare workers. So there's a reason for healthcare workers to come, nurses, clinicians, and then also, even from the programmatic side, that could be exposed to this. And, I think there's enough technical skill within the child pneumonia space where this can make sense. The things that came to mind for me would be around oxygen, pulse oximetry, high flow, CPAP, but diagnostics, with digital stethoscopes, cough tools and those things that are coming online. One can imagine, a really kind of interesting, fun, useful, interactive child pneumonia workshop. But again, we would need, the commitment from the union that we can have that space. And then it's going to require some, planning and funding to do that. And then the other aspect, which was really important for research capacity building, would be around, at least initially, abstract support for LMIC colleagues, so that, one of the things that we had kind of talked about and envisioned is even almost like a program where we can help to support and mentor as a community LMIC colleagues who want to submit an abstract to the union, and then attend the conference. And so that's kind of the other idea here. We want colleagues from LMICs to be able to come and actively participate and contribute to the group and to the child pneumonia space. And it does kind of circle back to the need for there being even the ability of having our child pneumonia abstracts accepted to the conference. I don't think that they're getting a lot of priority. I don't think the reviewers are necessarily have, the child pneumonia background, candidly. And so there's a lot of TV people reviewing these abstracts, and, they understandably, don't know necessarily what's important and what's not. Just as, perhaps I won't know exactly what's important in the TV space. So, and then the last thing on the list here is around our partner collaborations development. I mean, I think this is really, really key as we kind of move into the next 2-year cycle. Whether this group kind of gets its sea legs and really moves forward meaningfully, I think is going to take, more collaboration, and we really would like and are open to that. So those are the things that I wanted to go through, and we're actually pretty much on time because we really wanted to make sure that the room was open for comments and feedback. We have this room for another 20 to 25 minutes. That's really all that I have. I don't know, Rebecca, do you have anything else you wanted to add? Yeah.
That's all.
Yeah. Okay. Yeah. So let me, okay.
Okay. I'm Irene from PET, Indonesia. And PET globally is also working on oxygen, also working on pneumonia on child. Okay. On the oxygen respiratory itself, PET has been working in around 12 to 14 countries. Actually, that's how I met my new friend here, Joanne, and also the team, through my colleague in PET Zambia. So my question is related to, I know about a global forum on child pneumonia. And the second global forum was conducted last April 2023. And I understand I attended the session as well, the global forum. And when I heard the presentation from Joanne and also your explanation, I feel like deja vu. Seems like a great opportunity to integrate or to coordinate whatever the right term to use on this matter, because this, what you explained, really something that everybody need to work on together, including, for example, the global advocacy, for example. Yeah, I just want to know, me, to be honest, I attended this, I got the message about this session and we're asking whether I will join, and I said, okay, let me come, let me attend. and really grateful to attend. I would like to know between this TWG and that Global Forum on Child Pneumonia. Thank you. Forgive me for this question. Forgive me. I just attended this now today. Thank you.
We have a couple of questions and then
I just wonder whether Eric and Rebecca, could you just respond to that question?
Sure. Yeah. I mean, so I think from our perspective, we're certainly open to any and all collaborations. And I know, so Leith was involved, with the development of the global forum, and maybe can comment more specifically on that. One of the things that I had understood, but I was not at that last meeting. I was at maybe the first one. Was whether it was going to be continuing or not. I wasn't sure, but we are open to any and all collaborations. So that's kind of our principle.
Eric, I'm happy to update the group on that. We're very glad the question was asked.
Yeah.
So there's been two global pneumonia forums, they were called. The first in Barcelona in 2020, January, just before COVID hit, hugely successful. Then we came back in April 2023 with the second Global Pneumonia Forum in Madrid. What's really interesting is there will be a third, but it won't be a Global Pneumonia Forum. We were already, by the second one, pushing the envelope, frankly, to get the global health agencies to agree to focus on pneumonia. So the third one will be from the 22nd to the 25th of July in Mozambique. But it will not be called a Global Pneumonia Forum. It's more broad child infectious diseases. So it's a more broad positioning. So that was very interesting for us because we see the shift. There's a shift away from wanting to focus on single disease conditions, and for good reason, a lot of it. But so I think that strengthens the role actually of this group to keep the focus on childhood pneumonia. You will certainly be invited as a group to participate in the Mozambique Forum. So you'll have an opportunity as the union working group to come there and talk. But I think what's happened with the new event, and we've lost the title Global Pneumonia Forum, it just makes it more important that this group, charges forward.
That's super helpful context, Leith. Thank you. And again, I think, Leith, we can circle back to you in terms of who might be the right person to contact at that group so that we can better engage, as well.
So once again, Gates Foundation is the primary donor for that group. I think there's a little bit from USAID and maybe a little bit from Lakeisha Foundation. There is a committee that's organising that, and I'll be on that committee as I was for the earlier two. So I'm very happy to build those bridges with this group.
Thanks, Leith. Steve.
Yeah, just can I make some comments? Thanks, Eric, for the acknowledgement that I feel the fact that we're here now, perhaps in all of that time that we tried, I generally failed. So maybe my advice is not very worthwhile. But I would just reflect on a couple of things. I think the things that you're putting there as plans are excellent. There are less and less symposium at this union meeting, so oral abstract sessions or whatever can be just as good. And there's probably definitely space. There's so many pediatric TB symposium these days. I think it's time that we advocated for a bit more child lung health.
But how would you message that?
So we need to do this together. I see Matthew's put there, what about the union leadership, etc. But the union is a membership organisation. We are members. We have a voice to ask for what we want as members. So perhaps, if we can build our membership of the Child Pneumonia Working Group, but all of us here, many of us involved in TB as well as pneumonia. We can be voices for pneumonia, and I think it's important to remember that. So I know Andrew's tried hard. We've tried, but it's important to continue. If I could just quickly, I first came to the union, sorry to say, in 1996 to present on pneumocystis pneumonia as a major cause of death. and worked in the pneumonia space for a long time, perhaps. And the union, the Malawi Childline Health Project was a union project from 2000 to 2005, Gates funded, reduced deaths by doing exactly the things that Zach put up there. You know, it was just going to all the district hospitals in Malawi, making sure you implemented oxygen when it wasn't there, antibiotics were available and used, that everything was recorded, and it reduced mortality. I know, as Leith would say, that's a facility-based thing, but you know, this was excellent implementation research. Then the union was also responsible for labelling the oxygen working group, for labelling oxygen as an essential medicine. And we've sort of made these sort of contributions over time. But I think the union as an organisation, even in the TB space, has always been about working with programs, implementing, using the tools that we have and doing that better to get the right outcomes. And I think that's probably still, talking to Yassir's, but implementation research is probably still, I would say, where we're at. Rather than dividing into pathogens, that's always never going to work. I mean, Leith is right, RSV, these preventions coming along, that's all very exciting, but I don't see the union as being able to lead RSV interventions in low and middle income countries. I just don't really see that. But so that's just my broad summary of some of a perspective on these different things. There's so much, but I totally agree with the idea that we still need to stand for pneumonia and not divide it up into too many subsets. Oh, sorry. I did want to say, in terms of leverage here, I do think we need to talk to TB in the context of child pneumonia. And we know from the previous studies and also recently, Olivia was just here, TB speed, particularly pneumonia in kids with malnutrition. That's where that's the TB group. And that malnutrition area, again, is something that we need to speak to more, I think. But that, in terms of getting that leverage we want with the union, I wouldn't leave TB out of the discussion.
Steve, can you speak a little bit to the history of that pre-conference day, that's the child and adolescent TB group? Because I'm wondering if it might not be wise for us as a group to consider something similar, as you were alluding to, even if it's a 5 to 8 p.m. On that day, so that people can attend the child and adolescent TB group and then stay on for 3 hours of pneumonia. The WHO is there. It's essentially a bigger version of what we're doing today. Maybe we do a 3-hour session for 2 years and then it becomes a whole day thing. I remember that group when it started out being 50, 80 people. It's now 500 people. But, your thoughts on that, Steve? Because you've seen that develop.
Well, certainly we can lobby for that for the next child and adolescent TB working group for next year, to have representation of you guys to talk to the issues of child pneumonia within that context. With Chishala there, well, lots of people, but the malnutrition in TB is getting much, much more attention. We need to put the pneumonia in there as well. So yes, I absolutely agree. And then you've got the audience of 500 people, mainly pediatricians from low middle income countries who deal with respiratory disease.
Comments? We need contributions. That's what we call, but we need your contributions to see how we move this forward. Thank you.
Hi, everyone. I'm Justy Anthony Chilman. I'm from Cure.ai. We develop AI softwares for automated interpretation of chest X-rays. I'm a clinician myself, internal medicine, just like John. So I just wanted to add our X-ray software. It's called QXR, and we've had the expertise of developing it, and it's currently trained on 9 million chest X-rays, globally sourced. So currently we are deployed in about 93 countries in about 3,100 sites. And now earlier we were only focusing on adult TB. Now that we've gotten good at that, and we realized we're missing a lot of pediatric TB cases, we've actually enriched the model and we've developed a pediatric TB model. Now, when we started working with the pediatric TB model, obviously we're seeing that community health workers are the people who are using our AI software. So they're seeing a child who's having respiratory symptoms. Now, it's not going to be easy for them to figure out, is this going to be a pneumonia or TB? And they're going to err on the side of possibly overdiagnosis. So we have been actually linked.
I just asked something, and I have it, but if we are not here, should I?
Yeah. So, so we decided, so we also felt as a group that it's unacceptable having so many children die of pediatric respiratory illnesses. So we have started, we've been discussing with LEAP for over a year. So if we have to get into pediatric pneumonia, we realize that there has to be enough data set. For example, if we have to develop an AI for chest X-ray. So we started discussing with LEAP and many partners, including Dr. Nantanda from Uganda. And we decided to do a data collection exercise. So focusing on not just chest X-rays, but also on cough sounds, because that I think will become even more better point of care that even at a home level, we can figure out if a child has potential pneumonia and lung ultrasound. So we are looking at getting this proposal moving, provided we get the funding. That is one thing. I'm not sure if somebody from Meru Foundation is online, but I'd be happy to discuss. That is another project. Meru Foundation is one funding for evaluating children with respiratory symptoms and using, it's called Risk for Kids project in 2 sites in Bangladesh, where they will evaluate transcriptomic signatures as well as CAD and cough AI to differentiate between pediatric TB and pneumonia. So that is expected to be launched next month. So we'll get some idea because we also have consolidation algorithm. We do about 35 plus abnormalities on chest X-rays. So that is one early pilot. We can see whether our consolidation algorithm and our pediatric TB algorithm is able to help. If not, we are going to use, we'll have to put in more effort in training the AI algorithm. The last couple of things I want to mention is, as I mentioned, the community health workers, when they're dealing with a child with respiratory symptoms, we are also enabling an AI chatbot within our care coordination platform so that they can, because if you've seen the WHO guidelines, right? When a child comes with respiratory symptoms, there are many danger signs that they look for. And they are not able to, it's kind of complicated. So we thought, why not include large language model-based AI chatbots so that they can ask the questions on what are the specific danger signs, and they can say, it can be that they speak into the chatbot and say, no, is the skin looking dehydrated, or is the child looking pale? So those kind of questions. So that is another thing that we're working on. And the last thing is we are also evaluating point of care ultrasound AI for pediatric pneumonia. I think IMCI Plus is one of the databases, and we're also conversing with other investigators in this space. Just wanted to say that we are making, as a company, some movement in this space. Just wanted to add that.
Thank you. I don't know whether our colleagues online have some questions. We have a few minutes to go.
Can I just add to what Justy said really very quickly? Just to underscore, the proposal she's talking about is called Breath. I put the link in the chat. There's quite a few groups working on this. It's really terrific, but we're pretty much on our own, and we're struggling with the donors. But it's a really interesting proposal. We've gone public with it, and the Cure team have just been so patient, frankly, as we all sort of try and mobilize on this. But it raises the issue of could you produce, as a group, could you take the kind of childhood pneumonia research agenda under your wing and lead on it and produce not only a regular, even monthly list of the most important childhood pneumonia research publications? No one's doing that at the moment. It's beyond our coalition to do that. We don't have the time to do it. But also the active studies that are underway, not published yet, and the proposals that are really promising and seeking support. So those 3 categories, if this group could get behind that, I think it would fill a huge need and a gap.
It's a great suggestion, Leith. I don't see why not.
Your coordinator could do it. It's something you could do online, but even if every 2 weeks we got this in our inbox, we could see exactly what was published without having to search ourselves. We knew what was just beginning, like your new one, your blast one, Eric, and then this one, Breathe, and I'm sure there's many others where we're actively out there trying to mobilize.
Because ultimately, I mean, I think a lot of us who do research can, agree. A lot of the strategies, you kind of have a platform and then you add things on, and there's ways to kind of coordinate and synergize efforts, for that can meet the global good for what we're trying to do. Any other comments from the group?
Just a the turn this on. No, here we go. This is just a word I guess a word of encouragement and thanks. I want to thank Eric and Rebecca and the others who are working to make this happen, because I think that this is quite frustrating at times and taking quite a lot of persistence, and there are discouragements, and I think that it's worth it. And I want to thank Steve Graham for all the work that you have done over the years, Steve, again, and others. But this is the frustrations of trying to find a home for child pneumonia and trying to take that agenda forward. Those are real frustrations, but I think it's definitely worth sticking with this, because this is a no-brainer, right? You go to plenty of meetings and you're saying, this particular thing we're talking about is the 10th most whatever, and you think, fine, that's great, but like child pneumonia, it's just at the coalface and in the statistics, it's just right up there. You go and talk in any country, you talk to people who are dealing with these things on the ground, and they say, what are your leading causes of death? And they say, there's pneumonia, and there's right, it's just there. It happens all the time, doesn't it? And so this is definitely worth sticking with. And the making progress on the research front, making progress on the advocacy front. Really want to thank Leith for all of the work in that space, which is just so vital. And the fact that we sit and have this meeting, there's not a million of us here. But that doesn't mean this is not going to work and that it's not worth persisting with, because from so many angles, this looks like a no-brainer, something that really needs to be addressed. So I think that I think that's encouraging. So thanks and encouragement.
Thanks for that, Steve. I wanted to say Matt Kelly is our co-chair, our third co-chair, and I know it's very early in the US, but I wanted Matt I messaged you directly, but I wanted to see if there's anything else you wanted to, any additional remarks, if you'd like.
Yeah, thanks, Eric. And I have the baby with me, so I've been trying to type my messages in case things get disruptive. But I think I just wrote a message now. I mean, I know this is one of the smaller working groups. There, aren't a huge number of people online, but if you are in the room, but if you look at who's online, who's in the room, I mean, I really do feel like during these 2 years, we've made a huge amount of progress. There are well over double the number of people on this working group meeting compared to what we had last year. The plenary is a huge accomplishment. And I think we've got a good set of potential ways that we can continue to advocate for expanding the union as a home for childhood pneumonia. So I'm really enthusiastic about the idea of a workshop and about trying to find ways that we can increase the programming for pneumonia at union conferences, because I agree wholeheartedly. We need more motivation for child pneumonia researchers to attend the conference, participate in the working group, and really get involved. And I agree to some extent, at least initially, that's going to be how can we tie that to pediatric TB, or sort of draw on all the work that is being presented on pediatric TB at the conference. So thanks everybody for being in the room or online tonight. It's really, really great to have engaged partners like we have, and so many committed people to the success of this working group. Thanks.
Thanks, Matt. Rebecca, do you want to close us out? Maybe before, and as Rebecca comes up here, I do want to publicly acknowledge Andrew Steenhoff as well for his immense support, guidance, answering emails at any time, and also supporting Rebecca's attendance at the conference, so the CHOP Global Health Program. Thank you.
Okay. So it's time for us to end the meeting. I really just want to thank everyone for making time to attend this meeting. The people online, thank you for making time, but also very important for the great discussions we have had. We feel energized. We're kind of down when we came, but with all your support, with all the discussions we've had, and I'm really very hopeful that this is just a starting point. We are going to have more engagements. These things we've put together, we are also going to join hands and really make sure that they happen. Thank you so much. And I'm inviting everyone, please come tomorrow for that plenary session. It's at 11:10 up to 12:10. Invite a friend to invite a friend, invite everybody. Let's have childhood pneumonia get ahead within the union. Thank you so much. Have a great evening.
Thanks, everyone. Good luck tomorrow.
Thank
Bye-bye.
you.
Thank you.
Thank you.
Thank you.
Thank you. Bye, everyone online.